Hi, I'm Antonio Atalaya, and I work as a clinical advisor for the Euro-NMD coordination team. I'm pleased to welcome everybody to this webinar organized by the Euro-NMD in collaboration with the European Academy of Neurology and DRN for Rare Neurological Disorders. Today's webinar is about management of cardiac involvement in genetic myopathies and will be presented by Professor Karim Wahbi. Professor Wahbi is a cardiology professor at the University of Paris, France, and head of the Reference Center for Neuromuscular Cardiomyopathies in Cochin Hospital, Paris. He completed his cardiology internship and residency at the University of Paris Descartes. He specializes in the clinical management of patients with cardiomyopathies with a specific expertise in neuromuscular diseases. Key areas of clinical and fundamental research for Professor Wahbi are the prevention of heart failure and sudden death, the study of molecular mechanisms underlying cardiomyopathy, and the development of innovative therapies in patients with neuromuscular conditions. Thank you, Karim, for sharing your knowledge with us today. The floor is yours.
Complications or due to cardiovascular complications. So it is crucial to handle this problem and to offer patients preventive treatments that can be really beneficial to improve survival. It's impossible to present all aspects of management of neuromuscular cardiomyopathies in 45 minutes. So I will try to explain the rationale for following patients and treating patients. And the point is to convince you that cardiac preventive measures can really improve patient prognosis. So I will start with very general points on neuromuscular cardiomyopathy, and then I will go through some of the most common conditions such as Duchenne muscular dystrophy, myotonic dystrophy, and laminopathy. So a very basic question, which is why do patients with neuromuscular conditions develop cardiac involvement? I think very basically, the starting point is that there are great similarities between the cardiac and skeletal muscles. If you look at the protein whose gene mutations can cause myopathies, you can see that most of them are expressed at the cardiac level. So very basically, when you have a genetic condition with mutation in a given gene, you have an abnormal protein expression in the skeletal and in the cardiac muscle in many cases, and sometimes disease may target other systems as well. If you consider the issue of neuromuscular cardiomyopathies, you have two different and two very important aspects, which are firstly the involvement of the cardiac muscle, which results in the development of cardiomyopathies, and on the other hand, the involvement of the electrical system and electrical disease. Patients with neuromuscular cardiomyopathies generally have a dilated pattern. This is what we observe in most conditions. Less frequently, patients may have hypertrophic cardiomyopathy, which is characterized by a thickening of the ventricular walls and an increase of ventricular mass. This is generally observed in glycogen and lipid storage diseases and in some mitochondrial conditions. Restrictive pattern characterized by an increase of the filling pressure is relatively uncommon and is seen mainly in patients with desminopathies. So the prominent phenotype is dilated cardiomyopathy. And on the other hand, you can have various electrical abnormalities, either involvement of the conduction system, which is frequently seen in patients with myotonic dystrophy, laminopathies, desminopathies. Some patients may have ventricular tachyarrhythmias, It is highly prevalent in patients with laminopathies, desminopathies, or some other arrhythmogenic conditions. And some patients may have also supraventricular arrhythmias. This is seen in myotonic dystrophy, laminopathies, and some other arrhythmogenic conditions. And in the end, cardiomyopathy can result in the development of heart failure, which represents probably the most frequent cause of death in neuromuscular patients. And electrical abnormalities can result in events such as sudden death, either due to complete atrioventricular blocks or due to malignant ventricular tachyarrhythmias. And patients with atrial fibrillation can also have stroke, which represents a common cause of death, for example, in patients with laminopathies. So we can see that there can be various manifestations, and there are very different patterns from a disease to another. You know, if you take a number of neuromuscular conditions and the type of abnormalities that can be seen, with here myocardial involvement in heart failure, and on the right, electrical abnormalities, you can see that the prevalence of those abnormalities is very different from a condition to another. And this is the reason why you have to offer patients very specific strategies, preventive strategies, according to the type of disease which is diagnosed. For example, myotonic dystrophy type 1, conduction system disease is the most prevalent manifestation. In dystrophinopathies, Duchenne and Becker muscular dystrophy, patients have a high risk to develop dilated cardiomyopathy and heart failure, and electrical abnormalities are not so frequent. And you have conditions such as laminopathies or desminopathies where any kind of abnormalities can be seen. Another very general point, which is really crucial, is the fact that when myopathies are diagnosed, you generally can see that patients at that stage, in the majority of cases, do not have severe cardiac involvement. You know, there's a continuum in the development of cardiomyopathies, from very basically the functional molecular abnormalities that can be present to mild clinical abnormalities, and then more severe myocardial and electrical abnormalities, and in the end, potentially life-threatening complications. And in patients with myopathy at diagnosis, generally you see patients with normal or only mild myocardial involvement. And this means that you have place for prevention because you can intervene quite early in the course of the disease. And this is a chance for patients. And either treatments targeted heart failure or prevention of sudden death measure can be really efficient in this population for that reason. One very general point is also the issue of genotype-phenotype correlations regarding cardiac involvement. I think there is obviously a certain degree of genotype-phenotype correlations in several conditions, such as dystrophinopathies. You know, the myocardial involvement is more prevalent and more severe in patients with Duchenne muscular dystrophy compared with Becker muscular dystrophy or even female carriers. And you can see that also in patients with laminopathies, where we know that truncated mutations are probably more severe than other mutations. But the key message is that the type of mutation is sometimes a valuable information for risk stratification, but that you can't base patient management solely on that point. This is an information that you have to put together with other informations in order to estimate the risk for neuromuscular patients to develop cardiac involvement. And there's one reason for that, for the fact that genotype-phenotype correlations exist, but You can't absolutely predict patients' outcomes only regarding the type of mutation that patients may have. There are several reasons that can explain that. The first reason is that environmental factors can influence development of the disease, viral infections, degree of myocardial stress, exercise, and there are also epigenetic factors that are extremely difficult to estimate in routine setting, but that play a major role to explain the clinical variability regarding cardiac involvement. So now I will go through several neuromuscular conditions to show you preventive treatments that can be offered to our patients with neuromuscular disease, with firstly the heart failure issue, particularly through the example of Duchenne muscular dystrophy. As I told you, there's a continuum in the development of myocardial disease and heart failure. Patients generally have a progressive decline in their cardiac function. And the main issue in neuromuscular patients, the main question is when should preventive treatment should be started? We know in the general population that when cardiac function is significantly impaired, for example, if you use the left ventricular ejection fraction as a marker of cardiac function, when it is below 45%, there's a general consensus to suggest treating patients with heart failure medications. But the question is, should we start earlier this kind of treatment in order to improve long-term prognosis and to prevent the development of severe LV dysfunction? And I think this is a very important issue in neuromuscular patients. And I will show you through the example of Duchenne muscular dystrophy that treating earlier can really improve prognosis. You all know Duchenne muscular dystrophy, which is the most common neuromuscular condition in children. We know that the prevalence of dilated cardiomyopathy increases progressively with age. If you take children aged less than 10 years, it's relatively uncommon that you diagnose dilated cardiomyopathy, probably less than 5% of patients. But the prevalence of dilated cardiomyopathy increases progressively. And in the end, the majority of adult patients do have dilated cardiomyopathies and quite often heart failure. And if you take a look at the causes of death, you can see that terminal heart failure is one of the most common causes of death. So the question in those patients is, should we treat them once they have dilated cardiomyopathy, or should we put them on treatment earlier to prevent its development? So we have a very important study that has been published in 2005, which was a randomized trial. This is the first study who showed that prophylactic treatment with a very common treatment, ACE inhibitor. This is one of the most common treatments worldwide, and this is the first-line treatment for heart failure of any cause. While this study, which is a randomized trial, has shown that treating young patients with Duchenne muscular dystrophy around the age of 10 years, while they had a normal cardiac function, resulted in a significant prevention of the development of dilated cardiomyopathy. Patients were randomized between perindopril or placebo. And after 5 years of follow-up, you can see that patients here treated with perindopril were less likely than others to develop dilated cardiomyopathy and left ventricular systolic dysfunction. And when you prolonged follow-up at 10 years, you can see that patients were treated with perindopril rather than placebo were less likely to die and less likely to develop terminal heart failure. So you can see that this treatment is highly efficient to improve long-term prognosis, but it takes 10 years before you have an impact on survival by starting the treatment. More recently, this is a work we have submitted and will probably be published quite soon. We analyzed in a much larger population, more than 500 patients, the effects of preventive treatments by ACE inhibitors in patients with Duchenne muscular dystrophy, according to the same criteria. And we found quite the same effect in a real life setting, with a significant improvement of overall survival, 70% reduction of the risk of patients to die at 10 years. And this benefit was mainly driven by prevention of terminal heart failure and severe heart failure decompensations. So ACE inhibitors are now recommended by most experts worldwide for the treatment of left ventricular dysfunction in Duchenne muscular dystrophy, and are generally initiated by the age of 10 years. But this is not the only treatment which has proven efficacy. Steroids have also shown beneficial for cardiac protection in Duchenne muscular dystrophy. Unfortunately, we have no randomized trial, and we will never have a randomized trial assessing its efficacy at the cardiac level, but we have a number of retrospective studies which have shown pretty much the same thing, which is a beneficial effect in terms of prevention of development of dilated cardiomyopathy and improvement of long-term prognosis. This study is probably the most interesting one. This is a study which was conducted in Canada. It has shown that patients treated with steroids have a long-term significant reduction of overall mortality, mainly due to prevention of terminal heart failure. So if you take a look at the treatments that are currently recommended for the management of Duchenne muscular dystrophy, where you have corticosteroids, which is the first treatment initiated during patient life, and corticosteroids have initially been used mainly for skeletal, muscle, and respiratory treatment, but they are obviously efficient at the cardiac level also. And a bit later, around the age of 10 years, you have ACE inhibitors. And there's a trend toward putting patients under even more complete treatments, particularly because there are probably other heart failure medications which are efficient for cardiac protection. We have spironolactone, with a study published in Lancet Neurology a few years ago showing benefits on a surrogate, which was contractility assessed by MRI. So spironolactone is probably beneficial in those patients, and most experts recommend its use once patients have mild impairment of ventricular function or fibrosis on MRI. And there are also two ongoing studies assessing the effect of beta blockers, one in the UK and one in France, and we may possibly have to use beta blockers on top of ACE inhibitors in the ongoing years. So if you consider the issue of myocardial protection in a broader perspective, beyond the issue of cardiac protection in Duchenne muscular dystrophy, I would say that in any condition where patients are potentially at risk for developing heart failure, there is a question of the best indication of cardiac treatment. When should we start treatment such as ACE inhibitors in patients at risk for dilated cardiomyopathy? Obviously, when patients have an ejection fraction below 45%, there's an indication for medical therapy, ACE inhibitors and beta blockers. But probably in conditions where the risk is really high, such as Duchenne muscular dystrophy, we should probably put patients on treatment earlier. In Duchenne muscular dystrophy, you do that even when the ejection fraction is completely normal. in Becker muscular dystrophy, it is probably beneficial even when you have very mild abnormalities of the cardiac contractility and the borderline ejection fraction. And one great challenge in the future will be to improve the prediction of severe LV dysfunction quite early. And there are several tools that are currently being assessed to determine whether they can improve that prediction. Cardiac MRI, some tools we can use on echo, biomarkers, and also the analysis of the genetical background. And this will be really crucial, particularly at the era of gene therapy, to identify patients that are potentially eligible for such treatments. So I will move on now to sudden death prevention and management of electrical abnormalities. Sudden death is a major issue in several neuromuscular conditions. You can see, for example, in patients with myotonic dystrophy, laminopathies, desminopathies, that the annual risk for patients to die suddenly is approximately the same as in patients with cardiomyopathies of other causes or patients with myocardial infarction or heart failure. So this is a major concern for our patients, and it is very important to use prevention. Very similarly to what previously said on the development of myocardial abnormalities, when you diagnose conditions such as laminopathies or myotonic dystrophy, generally patients have only mild electrical abnormalities. And this leaves place for prevention, and prevention mainly relies on the placement of devices, which are the most efficient treatments for sudden death. Either pacemakers when patients are at risk for conduction system disease, or ICDs when patients have also risk to develop ventricular tachyarrhythmias. And the main difficulty is to determine what is the best moments, what are the best criteria to put those devices in patients at risk for sudden death. If you take the example of myotonic dystrophy, which is the most prevalent condition in adults, well, we know that patients are at risk for electrical abnormalities, mainly conduction defects, but also sometimes ventricular arrhythmias and supraventricular arrhythmias. And we know that the annual risk for patients to die suddenly is approximately 1% at the era of prevention, or probably either 3% if you took a look at natural history data. And patients are also at risk for developing heart failure, but this is a far less common complication. Sudden death is related to many potential factors, either primary cardiac abnormalities or sometimes due to also extra cardiac complications such as pulmonary embolism, because those patients are very high risk for venous thromboembolism, but sometimes also acute respiratory failure. And sudden cardiac death results in a majority of cases of conduction defects, mainly atrioventricular blocks, and sometimes ventricular tachyarrhythmias. Risk assessment in patients with myotonic dystrophy is very important, but also very challenging. If you use the ECG and the echo, so non-invasive assessments, you can identify some predictors for sudden death, which are mainly conduction defects, particularly when the PR and the QRS interval are at more than 120 and 240 milliseconds, and particularly when patients have left ventricular bunch block, but also in patients who have personal history of atrial fibrillation or familial history of sudden death. But the problem with ECG is that its predictive value is relatively low. So if you take a given patient or a group of patients with myotonic dystrophy, and if you consider the ECG findings, you can differentiate three groups. A group where patients have absolutely normal conduction time intervals. We know that in this group, the risk for sudden death is extremely low. So no pacing, no pacemakers are necessary. If you take the group with complete AV blocks, sinus pauses, when you know that the risk for sudden death is extremely high, and there's obviously an indication for putting a pacemaker. And if you take the group with an intermediate risk, with mild conduction defects, first degree AV block, bundle branch block on the ECG, we know that in this group, the risk is intermediate, probably 3 to 5% per year. So you need to discuss preventive measures and you need to discuss prophylactic pacing. But the question is, how can you select patients for such treatments? The first option is to use the ECG and the criteria previously mentioned. And another option is to use an invasive assessment of conduction system, what you call electrophysical study, which is based on the catheterization of the right heart, which allows measurements, accurate measurements of conduction parameters, and particularly the HV interval. And we know that when patients have a HV interval at more than 70 seconds in the general population, they are at greater risk to develop complete AV blocks and to die suddenly. And we know in patients with myotonic dystrophy that when you use EP study in patients with an abnormal ECG, you find quite often a prolonged HV interval. And we also know that when you implant pacemaker in patients with a HV interval at more than 70 seconds, well, a very high proportion of them, almost 50%, develop during follow-up major conduction blocks. This had been shown in a study published in 2002. And this resulted in the use of the EP study in many centers worldwide for risk stratifications in myotonic dystrophy. A few years later, our group has studied the effect of prophylactic pacing on those criteria using EP study on prognosis. The objective was very basically to determine whether patients undergoing such assessments had a reduced risk to die suddenly. So we compared patients with an abnormal ECG, the group with the intermediate risk, and we compared patients who underwent an EP study and a pacemaker to those who had only regular follow-up. And we found that patients with undergoing an invasive assessment had a reduced and improved life expectancy and a major reduction of the risk for sudden death of more than 70%. And the majority of groups worldwide tend to use the EP study now for risk stratification and to guide prophylactic pacing indications. We know that prophylactic pacing is efficient to improve prognosis, but there remain some patients who still die suddenly despite pacemaker placement. And there are two mechanisms, two causes that can explain that. The first one is that some patients develop ventricular tachyarrhythmias, and sometimes young patients do have sustained VT quite often on exercise and sometimes cardiac arrest. And the only criteria that have been identified so far to recommend the placement of an ICD rather than a pacemaker are the identification of non-sustained ventricular tachyarrhythmias on Holter ECG, which means that when you consider the placement of a pacemaker, you should carefully take a look at Holter ECG findings. And if patients have non-sustained VT, then you should probably rather implant an ICD. And probably when you do an EP study, if you trigger a ventricular arrhythmias, that represents a valuable indication for ICDs. And the second reason why patients with DM still die suddenly despite pacemakers is that a number of sudden deaths are not really related to major conduction defects, but rather to pulmonary embolism, and massive pulmonary embolism is unfortunately a common complication of myotonic dystrophy. And the only efficient treatment is thromboprophylaxis in situations at risk for venous thromboembolism in this population. So generally, it is recommended at diagnosis in patients with DM1 to do an ECG, an echo, and a Holter. If all that workups are normal, to see patients generally on a yearly basis, but you can also consider a follow-up every 2 years if everything is absolutely normal. If you find abnormalities on the ECG, then you should consider an EP study. And if the HV interval is below 70%, then patients can continue their follow-up on an annual basis. But if patients have a HV at more than 70 milliseconds, then you should consider the placement of a device. The first line treatment is pacemaker placement. And if patients have non-sustained VT, then you should implant an ICD. And if during follow-up patients develop symptoms or progression of conduction defects on the ECG, then you can redo an EP study. And the thromboprophylaxis is very important as well. So myotonic dystrophy is a typical example of a condition where sudden death is mainly related to conduction defects. And we'll move on now to laminopathies, which is typically a condition where sudden death is generally related to ventricular tachyarrhythmias. Well, you all know laminopathies, which are conditions that has been firstly described 20 years ago that can result in the development of skeletal involvement, particularly embryodiphus muscular dystrophy or limb girdle muscular dystrophy. And some patients may have isolated dilated cardiomyopathy. Laminopathies are probably the most arrhythmogenic condition, which means that this is probably the condition, the neuromuscular condition, where the patients have the greatest risk to die suddenly. So sudden death prevention is a major issue. We know from natural history study that patients generally firstly develop electrical abnormalities, generally in early adulthood, AV conduction defects that can progress toward the development of complete AV blocks, supraventricular arrhythmias, and atrial fibrillation is associated with a great morbidity because the risk of thromboembolic complications is really high. And generally, patients develop a bit later dilated cardiomyopathy and heart failure. We know that the cardiovascular course of those conditions is extremely severe compared to other of dilated cardiomyopathies of other causes. And we know that many patients, once they have severe conduction defects and they are implanted with a pacemaker, that a very high proportion of patients die suddenly because they further develop ventricular arrhythmias and they are not protected from ventricular tachyarrhythmias by their pacemakers. So the first line treatment is really ICD placement. In this study published in 2006, it has been shown that implanting an ICD in patients with laminopathies, even when they had a mild phenotype, mild conduction defect, resulted in the delivery of shocks by their devices in a very high proportion of cases. But we know that patients with laminopathies have very high risk to die suddenly. We know that ICDs represent the first line treatment, but the difficulty is to determine what are the best criteria to put ICDs. A very important study, cornerstone study published in 2012, has identified several predictors for malignant ventricular tachyarrhythmias. This study was based on the analysis of a European registry, and it has shown that male patients were at greater risk than females, that patients with non-missense mutations had also greater risk, but also evidence of non-sustained VT and Holter ECG and mild ventricular dysfunction on the echo. And patients with two or more than of those risk factors have an extremely high risk to die suddenly and are eligible for ICDs. And this is what is recommended in most cardiovascular guidelines on sudden death prevention. So you can use those very simple criteria, or you can use another approach which has been developed by our group. This is a quite recent paper. And in this study, we have analyzed data from our French registry with more than 600 patients. And based on the analysis of those data, we have developed a predictive score that provides a quantitative estimation of the risk for patients to die suddenly at 5 years. And we have validated this score in an external international population. And this score works really well. So you can use a calculator online. And with this estimation, you can quite easily see whether patients have potentially sufficient risk to justify the implantation of an ICD in primary prevention. In order to leave time for questions, I will go quickly through other neuromuscular conditions and just say a few words of some of the most common on those who have the significant risk for cardiovascular events. The first one is myotonic dystrophy type 2. Well, in DM2, the cardiac pattern is very similar to that observed in DM1. Have probably a high risk for patients to have dilated cardiomyopathy or supraventricular arrhythmias, but the main problem is also the progression towards complete AV block. But the phenotype is generally milder than in DM1, and major conduction defects generally occur later in life compared with DM1. Patients with mitochondrial myopathies have also high risk to develop cardiovascular complications, and particularly heart failure. In most conditions, patients develop hypertrophic cardiomyopathy and generally thereafter heart failure. This is particularly the case in patients with the MELAS mutation. And very specifically, patients with single large-scale deletions, and particularly those who have Kearns syndrome, have a very high risk to die suddenly due to complete AV block. So there's a need to implant pacemakers quite early once patients have an abnormal ECG with conduction defects. Patients with desminopathies have a very high risk to develop both terminal heart failure and sudden death. And there are also indications for primary implantations of ICDs in patients who have non-sustained VT or evidence of conduction system disease. Patients with FSH myopathies are probably a very low risk to develop cardiac abnormalities. If you take a look at the causes of death, and if you compare the cardiac prognosis with that of the general population, they are very close. So the risk for cardiac complications is extremely low in this population. And patients with limb girdle muscular dystrophies, particularly those with sarcoglycans, particularly delta sarcoglycans, but also patients with FKRP mutations and tachinopathies have also high risk to develop dilated cardiomyopathy and heart failure. So there's also place for prevention and early use of ACE inhibitors in patients with those conditions. So in conclusion, I would say that obviously cardiac involvement had a huge influence on vital prognosis in patients with neuromuscular conditions, and it's very important to have discussions between myologists and cardiologists to improve patients' management, and very locally in the center where we'll have the opportunity to work. It's very important to have a close relationship with cardiologists and to discuss the management of patients. And it's very important that you're able to specify to your to the cardiologist working with, that there are indications for prophylactic treatments, and that patients should be put on treatments quite early in the course of the disease, and not only and the strategies should not only based on that applied in the general population. Early diagnosis is crucial. If you want to implement prophylactic treatments, you have to see patients on a regular basis in order to be able to diagnose abnormalities quite early, because at that stage treatments are really more efficient. And obviously, it was the main objective of this presentation, preventive treatments are efficient. Heart failure preventive treatments, and obviously treatments for the prevention of sudden death. And you should use those treatments quite early if you want to improve patient long-term prognosis. This is not always easy because at diagnosis, you have generally, patients have generally other problems. They focus on skeletal muscle involvement and its disability consequences. But you have to think of the long-term prognosis and cardiac prevention at that stage, even if patients do not have any symptoms or do not complain of anything at the cardiac level. Well, thank you for your attention. I'd be happy to respond to any question you may have.
Thank you, Karim. It was a very nice presentation, very informative. And everybody can put questions clicking on the Q&A button. And there is a question from Melanie Borde that says, is the treatment of dilated cardiomyopathy in LGMDs like FKRP and others comparable to the treatment guidelines for patients with Duchenne?
Well, this is a difficult question because we do not have evidence of beneficial effect of the treatments, and we will probably never have, because the condition is far less prevalent than Duchenne muscular dystrophy. But I think it is very reasonable to treat patients once they have even mild abnormalities of the cardiac function, or if they have fibrosis on MRI, because we know very similarly to that what is observed in Duchenne, that heart failure will represent one of the most common causes of death. And we know that the safety of those treatments is really good. And we know that those treatments are generally well tolerated. So I think that you have to put patients on at least on ACE inhibitors once they have an ejection fraction of below 50% or at 50%, or if they have fibrosis on MRI.
Okay, so for the moment I see no other question in Q&A, but I have lots of questions, so
thank you.
Be patient with me. It's interesting because in these talks or in this area of the cardiomyopathies associated with muscular conditions, it seems that there are almost two different type of diseases, the written diseases and the muscle diseases, but I know that it's not true. But do you have an explanation why in DM1 or LMNA you have such a high risk of arrhythmic event much earlier than you have evidence of heart failure?
Yeah, you're pointing out a very, very important issue. I think it's interesting to put that into historical perspective. As cardiologists, we have been thinking for years that the risk for ventricular arrhythmias or conduction defects is correlated to fibrosis burden. And if patients have a lot of fibrosis, they have an impaired cardiac function, and they have high risk for arrhythmias. So in DCM, the main criteria to put ICDs is currently low ejection fraction of below 35%. But we have learned from rare conditions such as laminopathies that sometimes you can have a high risk for arrhythmias even when there is not so much fibrosis, particularly on the MRI, which means that there are indeed specific molecular mechanism and electrophysical mechanisms for arrhythmogenic conditions. In myotonic dystrophy type 1, we know that the prominent mechanism underlying electrical abnormalities is the cardiac channelopathy, sodium channelopathy. Patients have an abnormal splicing of SCN5A, the gene encoding the cardiac sodium channel, which results in abnormal function and in the development of conduction defects. In laminopathy, the mechanism has not been determined yet, but obviously there's something happening at the cellular level that triggers arrhythmias and all electrical manifestations. And we are currently looking into that with Antoine Muchir in Paris. And I think this is really crucial because it has major consequences, because it doesn't make sense to put ICDs solely on ejection fraction criteria. You must have specific criteria for each condition for whom the risk is high.
Yeah, absolutely. And that's really what happens in laminopathies, as your group has shown. So is there still any indication to put a pacemaker in a lamin patient?
No. I think we still see patients who have pacemakers and who are diagnosed with laminopathies once they have been implanted with a pacemaker. And even in that case, we have two options: either upgrading a pacemaker to an ICD, or just waiting at that moment, or waiting a few years before the battery is low before doing that upgrade. The risk for patients who have a pacemaker to die suddenly is so high that we currently do that upgrade at the moment when we have the diagnosis. So obviously, I think there is no indication for currently, no indications for ICDs in patients with laminopathies. The only situation where we discuss that is in very specific forms of the disease, which is congenital laminopathies, because sometimes you do not have place under the skin where you can put the ICD box. And in that case, you can discuss a pacemaker because this is the only option available. But aside from that, we should put an ICD in all patients.
Okay. So, and when you put some device, how do you decide between an ICD, a cardiac rehabilitation treatment with defibrillator, or proceed to a heart transplant? Is that all decided according to heart failure, ejection fraction, or what's the deal there?
Once patients develop severe heart failure, I think you have to address a very complex problem, because generally cardiac rehabilitation sometimes can be beneficial, but I would say that in the majority of cases, you're in a situation where the disease is so advanced that the damages are really irreversible, and you can sometimes improve things, but it doesn't, in my opinion, doesn't really change the course of the disease. And particularly for patients, for these conditions such as laminopathies or despinopathies, when patients have severe LV dysfunction, it's generally too late. And so...
So would you put a CRTD waiting for a heart transplant, for instance?
Generally, this is what we do. When patients have a device, we add a probe, and we tend to offer CRT. We even sometimes discuss CRT when patients have only mild LV dysfunction, if they have an indication for a device to prevent further worsening of LV function. But we looked into the preliminary data we have on that, laminopathies and desminopathies, and our impression is that unfortunately the benefit is very limited. We tried also CRT in patients with Duchenne muscular dystrophy, and we had few patients who had good response, but I think that overall the benefit is not so high. So we continue doing that, but I'm not really convinced by the effects, and we have to, in years, to carefully examine those data once we have more patients to definitely conclude on whether there's a beneficial effect or not.
Okay, I still don't have questions from the audience, but I still have one that I want to put, please. It's so our previous webinar was by Nicola Voet. She works at Radboud University and in Netherlands, and she talked about exercise in neuromuscular conditions. And of course, one of the issues was the tailoring of the exercise program according to the patients. And I think this patients who have cardiac problems are probably good to discuss in that point of view, because probably they benefit from some exercise, but at the same time, you have to do the right fine-tuning to avoid harming them. How do you do that?
Yeah, I completely agree with you. The problem is that it's very difficult to determine what is the most appropriate protocol. We know that in some conditions, there's a deleterious effect of exercise, and particularly in patients who practice competitive sports. This has been obviously shown in laminopathies, and this is probably the case in Becker muscular dystrophy and in dystrophinopathies in general. When you make the heart working too much, it probably creates damages. But on the other hand, we know in various cardiomyopathy that this is potentially beneficial. But so the difficulty is where to put the limit. And it's probably different from a condition to another. I would be very careful in Becker or in laminopathies. But no one had the answer to that question. We have quite often that discussion between cardiologists, but we do not really know what is the most appropriate protocol. And I think we will unfortunately hardly be able to respond to that question. So I think it's probably beneficial, but we have probably to be very careful when patients have signs of cardiac involvement, or if they have a condition at high risk, such as laminopathies.
Mm-hmm. Well, it seems that there are no further questions. I will probably close by thanking you, your very kind participation, and thanking all the attendees for being present. This webinar will be made available as well after this session on the Euro-NMD site, so people can revisit this discussion. And thank you very much. Bye now.
Bye bye. Thank you very much. Bye.